Voice Foundation Symposium for inviting me, especially Nancy Solomon, for her attention to me and exciting organization and planning this Friday morning discussion. Bauru is a medium city in southwestern Brazil, in the state of São Paulo, and here we have our first evidence. Philadelphia is known for its famous cheesesteaks, and Bauru is also known for its famous sandwich. Actually, the sandwich is named after the city. But let's talk about massage. We don't know when laryngeal massages were first used, but we have excellent contribution in the scientific literature since 1990 with Dr. Arnold Aronson. He described the manual treatment for the reduction of musculoskeletal tension associated with vocal hyperfunction to relax the perilaryngeal muscles and to balance the phonatory function. As Aronson wrote, all patients with voice disorders, regardless of etiology, should be tested for excess musculoskeletal tension, either as a primary or as a secondary cause of dysphonia. He described some principles basic to therapy for muscle tension associated with vocal hyperfunction. The first one is extrinsic and intrinsic laryngeal muscle cramping is responsible for abnormal voice. Reducing musculoskeletal tension releases in the inherent capability of the larynx to produce normal voice. When gently rubbing or kneading muscles relax, the larynx and become less painful. Lowering laryngeal position in the neck permits more normal phonation. We have one example here. Let's pay attention to the muscles of the neck and the voice during the communication of this.
Ontem eu acordei às 9h30, eu fiz unha, aí levei meu cachorro para passear, voltei, esquentei o almoço, almocei, já era umas 11 e pouco. Aí uma hora mais ou menos eu fui para academia, treinei, voltei, tomei banho, assisti o drone, que eu adoro.
Could you pay attention? It's okay? Let's go. Now let's go to the treatment. In 1993, Roy and Lipper applied the manual laryngeal musculoskeletal tension reduction technique for functional dysphonia, and Roy et al. In 1997 named it manual circumlaryngeal therapy. Some steps were described by Roy. I am showing you this video with these steps. You can see the description above the video, please. Faz para mim, completo. Desafio é quando o peixe vem. 10.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Tá bem, então eu vou fazer uma manipulação agora. Vamos fazer uma para mim, tá bom? and go on until they relax the larynx and improve the voice. Let's see another kind of laryngeal massage. Laryngeal manual therapy was described by Madsen and colleagues in 2009. It's based in her clinical observation that the sternocleidomastoid muscles are excessively tense in patients with MTD, muscle tension dysphonia, and we need to start to these muscles and proceed to supralaryngeal area, and we must do rotational massage, kneading, and stretching. This massage takes about 10 minutes. Clinicians stand behind the patient who is seated in a low-backed chair. We ask the patient to relax the mouth and shoulders. We start the massage in the parts with lesser tension and advance it to greater tension. Is the most comfortable for the patient and achieves a reduction in overall muscle tension most rapidly. Medicine recommends to apply a kneading action upwards and backwards from the midpoint of the mandible, as shown here. Then perform kneading from a more lateral position on the mandible toward the larynx. The first two stages can be repeated until the clinician feels that the maximum reduction in muscle tension has been achieved without causing the patient undue discomfort. If the larynx is positioned high neck, apply bilateral pressure to the superior edge of the thyroid cartilage so that the larynx is firmly but gently depressed. Afterwards, we can apply laryngeal depression to the thyroid lamina. If we can observe the lateral movement of the larynx increasing, this is an indication of reduction of tension. Now we are going to listen to a young woman before and after laryngeal manual therapy. Just a vowel R. Papers over the years that bringing us some scientific evidence. One important study was described by Madsen. She published a literature review on the evidence for laryngeal manual therapies in the treatment of MTD. She aimed to provide information about the types of laryngeal manual therapies and evidence base for their use. She found only 5 relevant peer-reviewed studies from Belgium, Finland, UK, and USA that investigate the effects of manual therapy either alone or in comparison with another technique. The positive effects observed were the symptoms reduced significantly, improvement in articulatory movements, improvement in the overall voice quality, ease of phonation, and less throat tiredness. She found that the positive findings of the reviewed papers do not reflect of one particular method of manual therapy. Further research might explore the relative effectiveness of different methods of manual therapy in the perilaryngeal area. In her words, she concluded that the findings concur with earlier studies, although there is a paucity of evidence in this field. there is a need for high-quality evidence in the form of large, well-designed studies, including randomized controlled trials. This study was recently published at Journal Voice by both our and Dr. Belal's research groups. Thank you, Dr. Mara Belal. The purpose was to systematically review the literature and to analyze the effectiveness of laryngeal manual therapy in addressing the overall severity of vocal deviation, the intensity of vocal and laryngeal symptoms, and musculoskeletal pain in adults with behavioral dysphonia. Here we can see the criteria for considering studies for this review. The clinical question that underlines this systematic review was, what is the effectiveness of laryngeal manual therapy compared to other interventions in adults with behavioral dysphonia? We included just clinical trials. 2 independent authors select trials, and they agreed in 1995 in the reading and selection of papers. The unit terms used were population, dysphonia or voice disorders, and interventions, therapeutic or rehabilitation or voice training or massage. The researcher found 2,135 studies that were identified in databases and in manual search, but 2,099 were excluded on the reading, the title, and abstract. 26 were excluded on the reading, the full article. They were not clinical trial or with dysphonic individuals. Only 3 studies were considered for the analysis. Let's take a look in these studies. The first one is from Van Leer and colleagues in 2010. The objective was to measure the effectiveness of vocalization with abnormal breath support and manual circumlaryngeal therapy in patients with MTD. The assessment before and after interventions was the measure of the dysphonia severity index. The results showed that overall vocal quality improved after MCT, and the authors concluded that manual circumlaryngeal therapy is an effective treatment technique for patients with elevated laryngeal position, increased laryngeal muscle tension, and muscle tension dysphonia. But the precise way in which MCT has an effect on vocal quality has not been addressed in this experiment. The second one was the study by Anyanya and colleagues in 2014. The purpose was to compare the effects of manual perilaryngeal massage and traditional vocal training in professors with voice complaints. 42 professors were divided into 2 groups, perilaryngeal manual massage or vocal training. The assessments were self-perceived vocal and pain evaluation, vocal symptoms report, cervical muscle tension evaluation, perceptual auditory and acoustic voice analysis. The results in both groups, there was improvement in vocal symptoms. No difference was found among the interventions regarding scores in the vocal self-assessment questionnaire and acoustic analysis. There were some intergroup difference in perceptual analysis. The authors concluded that both interventions improved the subject's well-being and vocal quality. And the third one was our research group from Bauru, who compared transcutaneous electrical nerve stimulation to laryngeal manual therapy in 20 dysphonic women before and after 12 20-minute sessions. We assessed vocal and laryngeal symptoms, pain and voice quality. And what have we found? We found improved sore throat symptoms, decreased neck pain. We couldn't observe any changes in vocal quality in 12 sessions. The conclusion was TENS and LMT are good therapeutic sources, but need the addition of speech therapy and vocal training and guidelines regarding vocal health, for example, to further enhance voice quality and laryngeal aspects. Let's back to the review. Our methodology included the Cochrane library proposed along with the Cochrane Review Manager 5.3 software regarding of 3 studies. We have some steps for that analysis. Assessment of risk of bias, measures of treatment effects, assessment of heterogeneity. As we can see on this figure, green means low risk here. Yellow means unclear risk. The information was there but didn't meet our criteria. And red means high risk of bias. 2 studies showed unclear risk of bias regarding blinding of the participants and blinding of outcome assessments. And 1 study showed high risk of random sequence generation and application concealment. The same study showed unclear risk of bias regarding blinding of the participants. The analysis shows that the relative risk of improvement in the overall degree of vocal deviation in the intensity of vocal and laryngeal symptoms and in musculoskeletal pain by those who were exposed to laryngeal manual therapy is not different for the relative risk of improvement of those who were subject to other interventions. The assessment of clinical heterogeneity showed that regarding type of LMT, we found 1 laryngeal manual therapy, 1 perilaryngeal manual massage, and 1 circumlaryngeal manual therapy. We found 2 studies with association of LMT and vocalization, and 1 study with vocal exercises. The summary is, the research on laryngeal manual therapy shows great diversity of diagnosis, participants, and types of studies, but most studies have low levels of scientific evidence. There are several types of laryngeal manual therapy with similar objectives and effects, but they are as effective as other interventions involving direct voice therapy in the rehabilitation of adults with behavioral dysphonia. The good news is that we have 2 other studies. Here we have another study by our group about immediate effects of laryngeal manual therapy in comparison to TENS, and we found decreasing pain intensity on the neck, shoulders, lower back, and temporal area. And we observed improvement in general voice quality, decrease in tension and breathiness. Patients reported improved laryngeal and articulation sensations, and we concluded that TENS and LMT may be used in the voice treatment of women who have functional dysphonia. Both techniques are important therapeutic resources that can decrease in muscle pain and positively affects the larynx. In a single session, TENS and LMT partially improved vocal quality. Now we have this study by Dukan and Trevor. Their research verified long-term effects of manual circumlaryngeal therapy in the treatment of MTD, muscle tension dysphonia, based on acoustic and perceptual analysis. The study with 28 adult female patients showed after 15 sessions of therapy, 30 minutes, that MCT can be an effective method for voice rehabilitation in patients with muscle tension dysphonia. The authors found that harmonic noise ratio increased, jitter and tremor decreased, and the vocal quality improved in all patients. In conclusion, manual circumlaryngeal therapy can be an effective method for voice rehabilitation in patients with MTD. The results were persistent over 6 months after the treatment. We need more studies like this. Thank you. Thank you, Dr. Shepherd. I'm almost the end. When choosing the best method for the case, the clinicians should pay attention to the particularities of vocal behavior and participation of the cervical or perilaryngeal muscles during vocal production. MMT treatment effect is not different from that other direct interventions, which in this case were transcutaneous electrical nerve stimulation or vocal training composed of the tongue or lip trill, humming, over-articulation, and tuning techniques. We need clinical trials to improve the level of scientific evidence available and to enable research on the effectiveness of the procedure in comparison to other interventions. Although the number of high-level clinical trials is limited, this study showed an increased number of studies on laryngeal manual therapy. Now, thank you. This is our team in Brazil.